Good evening, everyone. That would be my absolute privilege. I have been knowing Dr. Kuhl for many years now and tried to role model many things, including my teaching style and the way I carry myself, except being late part. That I'm still learning.
You don't control traffic, Nergis, especially in this area.
As someone with like supposedly KGB background, I kind of want to feel like I can. But Dr. Kuhl, as a program director in internal medicine residency at St. Agnes Healthcare in Baltimore, Maryland. She's a faculty University of Maryland School of Medicine and active council member of the Governor's Council of the American College of Physicians for the state of Maryland since 2004. She has held multiple leadership positions at the state level and currently co-chairs the Mulholland Miller Resident Research Meeting, which hosts over 250 clinical vignettes and research posters, as well as oral presentation. And she also co-chairs the Women Medicine Committee for Maryland. She is the current National Community Hospital Assembly co-chair for the Association of Program Directors in Internal Medicine. She's also the she's also on the Association of Graduate Medical Education Residency Review Committee since 2020. She's on the board of the Journal of Community Hospital Internal Medicine Perspectives, a reviewer for the journal. Dr. Kuhl is a board certified internal medicine and received her undergraduate degree in biophysics from Johns Hopkins and her doctorate from the University of Maryland School of Medicine. She completed her internal medicine residency in University of Maryland, and she has worked as a hospitalist and then in a private practice before moving into graduate medical education leadership. She was awarded the Lockhart Conway Award in 2013 by ACP Maryland chapter for her contributions to resident education and research, and was inducted into the Healing Hands Society at St. Agnes in 2019. Dr. Kuhl's interests lie in promoting evidence-based medicine, communication, emotional intelligence, reducing healthcare costs and disparities. She is married, has 2 children, and enjoys painting, gardening, reading, and outdoor activities. And I'm just humbled and proud to call her my friend and mentor.
Nergis, that was very, very generous and kind. Thank you very much, and welcome everybody to the Women in Medicine at ACP Maryland. We're so happy you could join us, and we hope that the talks today are thought-provoking and hopeful. And please feel free to share your thoughts at the end, and we hope to have a lively discussion to support women in Maryland today. So I'm going to talk about something that is a little near and dear to my heart, which is fertility in women physicians. And I just want to say that these are my own views and not of any organization affiliation I have. Next slide. I think we've come a long way since the days of Elizabeth Blackwell and fighting for the rights of women in medicine. And just in 2019 was, I think, the first time in the US, across the US, there was majority women entering medical school class. So we've come a long, long way, but we know there's a long way to go. And I just want to say that what I talk about with the fertility issues may not be the right thing for everyone. I just want to make sure that it's only for people who may be interested in childbearing and want this as part of their life. And I have a lot of wonderful friends who have chosen not to have children and are perfectly happy. So I just want to couch whatever I say in that vein. Next slide. I get asked a lot of times over the many years of training and mentoring folks that, when is a good time to have a child in medical training? And I remember wondering that myself. As most of us know, it's you keep working and training well into your prime reproductive years. And medical school never seems like a good time. And residency often doesn't feel like a good time with the long hours. And if you were to go out, then you put a burden on others, and it just feels like you don't have any good time. If you want to go for fellowship or look for other career opportunities, that doesn't seem like a good time either. Your first job is often stressful with a steep learning curve, and you're trying to impress everyone and may not also feel like a good time. The other thing that often happens is that you're often into your 30s by then. And I got to learn firsthand about something that I hadn't thought much about, which was secondary infertility. As you age and have an increase in complications with pregnancies. Next slide. So I just want to tell you my story. And that first picture is my mom. I grew up in India. My mom's an OBGYN and treated a lot of people with fertility issues. So I was quite attuned to the fact that 30 was a magic number. Growing up, that if I really wanted to have kids, I want to at least have one child before 30, because I would hear of my mom's experiences over the years. She had two sisters who were also OBGYNs, a lot of fertility talk at family things, events. So I was lucky enough to have one child before the age of 30 while I was in my third year of residency, but I was also in the era of before duty hours and working 80 plus hours a week. And with my daughter, I developed complications, preeclampsia and HELLP syndrome, and got quite sick and delivered prematurely with a C-section at that time. And because I got so sick at that time, it was a little scary to think about a second child for a couple of years. And then when we did try again, I experienced what I later found out is pretty common, which is secondary infertility for women in 30s who may have had the first child but struggled to have more. And 3 years and a lot of treatments later, as you can see, we did have a beautiful boy who is now 12. And I just share my story because I think that I was not able to carry the child to term, and I never thought I would struggle with this as much as I did. And those 3 years were quite hell. And I wouldn't want women to have to go through that themselves. So next slide. So what does the data show about this issue? 1 in 4 women will suffer, female physicians suffer from infertility. The average age of diagnosis is around 33 to 34. And typically for physicians, the average age of first pregnancy is around 30. What's interesting about the infertility issue is that it's almost twice the rate of the US general population. Now, some of it may be that we're delaying childbearing, as many women due to professional choices may choose to do that. And there's studies outside of the US from Canada as well, where the median age of childbirth for physicians is often later. Typically, when you look at general population, the first child is around 27. Next slide. So what triggered my interest again in this topic is because there's been a lot of talk now and people, a lot more women are speaking out about this. When I had my problems, I sort of, did what a lot of people do, which is be embarrassed and ashamed and not speak out about it, and try to deal with it the best we can and keep going. But this was an article in the New York Times recently. Next slide. And one of the physicians who spoke out in this article is Dr. Ariella Marshall, a hematologist at the Mayo Clinic in Minnesota. And she talked about how at age 34, she's achieved everything. She was a high school valedictorian, attended top schools, and has been struggling to have children. And when she reached out to other female physicians, she found that there was a lot of people out there in her line of work struggling with this, either with infertility or carrying a baby to term. Next slide. So looking through the literature and there is of course not a ton of data, but there is some survey data out there. And this is a sample of random sample of 600 female physicians who graduated medical school between 1995 and 2000. And I happen to be in that group myself. And they talked about, asked them what they would do differently. And about a third of them said they would have attempted to conceive earlier. And about 18% said they would have used cryopreservation. Vast majority may have continued to do the same as they did. In this group, 82% were parents, 77% had biological children with an average of 2.3 children. But a lot of the talk that you see in the literature with this issue is around the costs of fertility, not just the financial costs, which by the way are substantial, and most insurances don't cover it, but more than that, it's the emotional and the physical costs of going through multiple procedures, multiple injections, countless injections, and feelings of inadequacy. Next slide. What is the literature around female surgeons? And it's very similar. And there's, again, a lot more interest in this topic and publications. This is another one from 2021 that talks about how women physicians, women surgeons are having fewer children, 1.8 versus 2.3. They're much more likely to delay having children because of their training, and they're much more likely to use assisted reproductive technology. As you can see, about a quarter of them end up using that compared to their male surgeon counterparts in this study. What surprised me was how many suffered a pregnancy loss. 42% had a pregnancy loss, about twice the rate of the normal population. Having suffered a pregnancy loss myself, I think that the emotional burden of this can be big for many people. There's also more data that I don't have time today to go into, but there's a lot more literature around pregnancy complications for physicians and surgeons compared to the normal population as well. Next slide. So what does the data show when we ask residents, when they're in training, what are women residents thinking? And this is a multi-center survey of female residents just published last year. And it was an anonymous survey sent out to about 1,500 female residents across 78 graduate medical programs, about 52% response rate, which is pretty good for physicians. And about 56% of the respondents were married or partnered. A large percent were delaying childbearing because, and these were the reasons they gave: busy work schedule, desire not to extend training, lack of access to childcare, financial concerns, burdening colleagues, and busy work environments, not feeling like the environment is supportive, and risks of pregnancy complications. Only about 38% of the ones surveyed were happy with the choice of delaying. Next slide. So I'm not going to spend a ton of time with further data, but to bring this issue up to light and to talk about us amongst women physicians, that I feel an obligation to tell the generation behind me, the younger women, that this can be a challenge and that they should make informed choices while they still have options. We control everything. We're very good about that. That's what makes us good doctors. We try to control so many things in our lives, but this is one thing that at this time we certainly are challenged. Next slide. So I reviewed a lot of data on the impact of stress on fertility, pregnancy, IVF, and there's a fair amount of data both that it makes an impact and it doesn't. So the bottom line here and the biggest takeaway was that we don't really understand fully how stress impacts fertility, but it does play a role for many. And so people who do engage in stress reduction techniques can find it beneficial and does seem to help with pregnancy for some. But again, we don't have a complete grasp on this issue and on conception rates. So next slide. I thought I would just ask folks, what do you think might be the success rate for IVF? Luckily, hopefully you never have to think about this, but do you think it's 4%, 12%, 24%, 37%, 48%? Any thoughts? 12% is what I see someone may have said, Sirin. Good thoughts. I mean, I think the problem is all of the above, 37%. 37%, 24%. I see that the answers are coming in, and I think you're all correct. Because if you go to the next slide, you will find that this is data right off the CDC website, that it really depends. And it really depends on the age, your age as a patient. So if it's under 35, the percent of retrievals that result in singleton live births, 47%. But if you're over 43, it is less than 4%. And so you can see that there is a wide variability, and there are multiple factors that affect ART. And so it isn't as optimistic as many think. And sometimes once you're deep into it is when you really realize and you don't have what you really need, which is the ability to go back in time. Next slide. So in that same vein, this was an article published by Dr. Ariella Marshall that I mentioned from Mayo Clinic, Vinith Arora, who's been an educator at the University of Chicago that I know personally for many years, and Dr. Salz, who I also quoted, about a call to action that this fertility should not be a factor that limits women's engagement in the medical workforce. And as we have majority of physicians moving to that direction of majority of physicians being women, this is something that we need to tackle head on. We definitely need to increase education and awareness of this. And so one of the things that these women physicians have done is created and worked with AMWA to have the first national physician fertility summit this year. And they've also are in the works of developing this new infertility task force to increase awareness and to help women physicians through these difficult times. Next slide. The other things that they bring up, which I think are very valid as well, is to provide insurance coverage. It's not just the insult of not being able to bear a child, but then the amount of money you will spend or can end up spending trying to get have a baby can easily run into the tens of thousands to $20,000-$30,000. And most insurances do not cover fertility treatment. There's also should be more support for trainees and physicians who undergo fertility treatments, like flex work policies and a focus on training and physician well-being so people feel supported in what can be challenging times. Next slide. I think that at the end of the day, wherever we look, even studies show still that majority of the domestic needs fall in dual career partners, career couples falls on the women. So I think women still end up doing the bulk of the work. But if you're lucky and can find a good partner, it makes all the difference in the world. And I don't know if I could be able to do half the things I can today without the support of my husband. But ultimately, I think we need to figure out our trade-offs and make sure that our values are what we keep front and center. And to recognize we're not alone and to speak out more and support each other through these challenges. Next slide. I think there's a lot of talk right now, and I had just recently had one of my residents come to me asking me about egg freezing and whether I would recommend it. Granted, I'm not an OB/GYN and have very little knowledge of it, but I was quickly looking it up with her to try to figure this out. And as you may have heard, a lot of the big tech companies have been talking about this for the last several years and offering it as the hot new perk, which brings with it its own challenges in the message it's sending to women employees about what is valued, maybe the fact that you continue to work or family. So that's controversial in itself. But I know this is something that more that wasn't an option that I was aware of when I was going through, but is increasingly a great option for many women. Next slide. So in my quick research, I found that there's a wide range of costs of egg freezing. And typically the highest yield, of course, is if you freeze your eggs before age 30. But even for the best chance of success, you need about 10 eggs for a 34-year-old woman to have a 75% chance of having one live birth. And if you freeze them much later on in life, as I've talked to some folks, they struggle to have eggs of good quality, and that can be very challenging. So I think if this is something that is important to you and you're interested to please look into it yourselves. Next slide. These are my final thoughts on this. I think it is a difficult topic. We haven't talked about it enough, and I just wanted to share my story so that if I can help one more person not go through these challenges and to go into their choices with their eyes open, I would feel very gratified. I think if relationships are important for you, you need to pursue them because there's never a perfect time for any of this. And life is messier than it looks, and most of us have it much messier than it seems from the outside and on social media. And I think that's perfectly okay. Next slide. And I thank you for that's my portion. And then I'm going to hand it over to Nargis to introduce our next speaker.
Sapna, thank you so much. Your presentation certainly evokes so much thought, emotion, and reflection. We really appreciate that. Thank you. Dr. Mira Newman is next, and she has been a teacher, primary care internist, medical leader in multiple venues. She loves Maryland chapter of ACP and was our very first woman governor. She will talk about the perils and pitfalls of aging as internist. And please We are all ears. Thank you so much for joining us today.
Oh, I'm so glad to be here with you. So here is, can you see my screen okay? Is it okay, Satya? Thank you. So this right here is my son, the older child, the older person here. He is turning 39 next week. He was the first Osler Marine baby born to a woman resident back in 1982. And that's his son, Santiago, who is my grandson and Jay's second child. So I put them in here just because I like to have personal pictures in a presentation. But I'm hoping I can come up with some things about aging that everyone except Colleen won't know them all, but Colleen may know them all. So here is our standard picture of an aging physician. It's an older man taking care of a young patient, and that's our prototype. That's who we think about. I don't think it's very easy to find a picture of an aging woman physician. And I thought, oh, I'll have this jam-packed with facts presentation. And then I realized I couldn't find too many facts. So I had to sort of pull strings together and threads together from various places to talk on this subject. So, the big physician's health study, you will notice, was from Harvard. It was a Harvard Medical School class, U.S. male physicians aged 40 to 84, no women. So there's a lot we don't know about aging for women physicians, but there's some things we can pull in from other places. So this is the first time I was called elderly. I was pregnant with my oldest, my son, and I'm an elderly prima gravida, giving birth to him at 30.4 years, Sapna. And then I too had secondary infertility from hyperprolactinemia, which is the low-tech version of infertility because it can be cured by 8 pills at a very low price and no doctor visits. So what do we know about the aging in women internists? Well, we know aging's an uneven thing, and it's different for all of us. It's internal, it's external, it's how you're perceived by other members of your profession. Particularly wrenching for me was the time I responded to an arrest and my hair was already gray, was at the airport. We're resuscitating an elderly man. And this young, 30-something male pediatrician's running the show. And he's bossing everybody around. And we have defibrillated this elderly man. He sits up, he's talking to us. And this young physician says, well, it says to shock him again, let's shock him. And I say, no, he's talking. And he says, but his brain's not being perfused. And I'm going, nobody in this group is listening to me, but they did hold off on shocking him. But I think, we have lots of examples of women being ignored in situations where they tried to take charge of this area in which they were competent to perform. We know the physicians are held in high esteem. We know the women physicians have better health outcomes for their patients. The patients like us better. But we have to have our children during the most important growth period in our careers. We know we earn less. There's loads of data about that. We know our net worths are lower. So that gets to be a real issue as we get older. Our net worths are lower. Now, depending on who you're married to, your net worth may be fine, or you might not be married, or you might be the principal breadwinner. We're also more likely to work part-time. We have a great tendency to pick lower paying specialties. So that all gets filtered into end of career issues. COVID was hard on us. There's loads of data from the AAMC that we had more role strain and it worsened our economic inequities. And then we face the end of our lives having 20% more time living with disability. And we live longer and we're more likely to be widowed. So all of those things are part of how we look at old age. And, I think all of us who have successfully saved for our retirement realize you have to start being realistic younger, not later. So this is the typical unfair disease that hits women much harder than men. This is osteoarthritis. Now, I picked this particular slide because this is CMC osteoarthritis, or osteoarthritis at the base of the thumb. Our anatomy predisposes us to worse hand arthritis. Now, if you're an internist or a psychiatrist, it's not so bad. But what if you're a gastroenterologist? What if it cuts you short by 10 years? I mean, many of the gastroenterologists, men and women, and also GYNs, who I know who have retired a little younger than their peers, were people with bad carpal tunnel, bad hand arthritis, or bad CMC osteoarthritis. It's a professional crisis. Bronchoscopists, same problem. So what are some things that are pretty common that affect the performance of our jobs? Vision, visual problems are common with aging. Reading speed. How many people know how much reading speed you lose as you age? This was something I had no idea. I looked it up for this talk. We lose, by age 58, we're down 30%. Now, when you're reading the electronic medical record, reams of paper, reams of input, it's hard to keep up. Interestingly enough, typing speed doesn't change. If you're a good typist, you stay a good typist. Those of us who are poor typists, I'm not sure how we're going to do. Processing speed goes down. Memory, there's several areas of memory that change. Our working memory declines, so it's harder to do more things at once. Our ability to use language stays pretty good. Episodic memory declines, and the ability to predict into the future or work into the future, like remembering to do something tomorrow, gets worse. And our procedural memory stays pretty good. Most of us could continue to do things we've done 100 times. We can keep on doing it. So here's some neurologic things, and they're probably the most critical. And there's some overlap in this slide. Just think about it. Smell declines with aging, COVID or not. So anyone who can tell strep when they smell it, or knows the smell of C. diff, if you lose your smell, you won't have that for yourself. Hearing is a very common disability, and it hits many of us. And, what happens to you when you're trying to listen to a heart murmur? You can get amplification. It's really important, if you are a person who's losing your hearing, to master the art of using hearing aids. They're getting better and better, but they're still super expensive. Touch can be a problem for some. Some people get peripheral neuropathy. Some people start losing their dexterity and fine motor skills and balance. Neuropathy or tremor is a big problem if you're a surgeon or doing fine work. And even issues of executive functioning and attention can change with aging. Crystallized intelligence or complex problem solving often stays very good with aging. So these are the specialties that are aging the most. So there are very few old interventional radiologists. There are very many aging pulmonary physicians, probably because some are in critical care at younger ages. But, there's a lot of old physicians. And COVID has really accelerated retirements and cutting back on hours and assignments. So we know we're on the verge of a primary care crisis. And there are many areas of medicine that are very old. So I loved learning about this. There are, if you look at people who make it to 100, there's 3 types. There are the survivors. They had serious illness of some sort, like a cancer, and they got through it and continued to be 100. Delayers are those who don't get serious medical illness till they're 80 or so. Those are the ones who don't get arthritis till they're 80. Those are the ones who don't get hypertension or diabetes till late in life. And then there's this amazing group of escapers. And the men who are escapers, who never really get anything, they are more represented. Even though the group of people who make it to 100 is predominantly women, there are more escapers in men, whereas we tend to be delayers and survivors. So what percentage of physicians are disabled as they age? Well, this is from the AAMC 2019 sample, and only 3% were disabled. And the average age of the disabled physicians was 54. So it is a later life experience, but I'm sure some of you can think of people you know who left medicine from disability at a younger age, or whose disability started to impact their ability to work. The most common were the mobility issues, psychological issues, and others such as hearing, essential tremor. Actually, ADHD is not an uncommon cause of disability in physicians, which I think is interesting, having personally known someone who, after treatment for ADHD, could finish passing her boards. So I was thinking of some of the things that are unfair in aging. It's better to be a female when it comes to baldness, when it comes to accidents, early coronary disease. Very few women have coronary artery disease that is symptomatic before they're 65. And COVID, we're better off with that. But it's better to be a male when it comes to osteoarthritis, which they get as much as a decade later. Widowhood, much more common for us. Autoimmune disorders, much more common for us. They both basically don't get osteoporosis. Now, I think most physicians know to be screened and to, not get osteoporosis and prevent it. Strokes are more common in women. Survival after MI is worse in us. Urinary tract infections with concomitant sepsis is worse for women. And this is one that is odd, but if you think about it, you'll comprehend it, which is that getting emergency care for an illness. A woman is much less likely to have a spouse who will demand that they get taken to the ER. Whereas men commonly have a wife who will, or a daughter, or a woman in their life who will demand that they get emergency care. So we are not coached for care the way men are coached for care. So this is another fascinating subject. I don't know if you've heard of optimism bias. It's been around a long time. It is one of the best studied of all of the cognitive biases. And I learned about it recently reading about vaccine hesitancy. It's the people who are most hesitant to get vaccines are in some ways the most optimistic. They truly believe, especially about COVID, that they'll be okay. But this is the bias that makes people buy lottery tickets. It makes them delay care for things that need to be cared for. They don't believe it's likely they'll get divorced. It's why we don't want to buy insurance sometimes. And it's a really common way of looking at your future and thinking, everything will be fine. I think it probably ties in beautifully with Sapna's talk, because that optimism bias says, oh, I can have a kid at 43. So one of the ways which the whole profession is taking a hard look at, are we still okay to practice? A long time, physicians were just left to practice as long as they wanted. But hospital boards, and this is comes from research published by Harvard in 1994 about the changes in the brain as we age. But this is the California board's hospital boards plan that after you hit 72, you need to start thinking about competency. A surgeon study in 2006 showed that for complicated operations, the mortality rate was higher for physicians over 60. So periodically, we need to think about ourselves and how are we aging? How's our cognition? How's our mobility? Do I still have the skills I need for my job? How long does it take me to recover from night or weekend call? Should I still be doing it? Should I still be working the same hours if I'm reading slower, thinking slower, and takes me longer to solve problems? Where am I financially in terms of how I'm doing in life? What are my family issues? Do I have a disabled spouse? Do I have disabled parents? And can I adjust and accommodate so that my life is still feasible? We hate to squeeze out all our fun, all our exercise, all our healthy behaviors because it takes us longer to do our job. So I think that's one of the things we all need to start thinking about. And somebody needs to start doing more research so we have data and information and advice that's useful. So, now this has been a kind of a downer of a talk, but, wisdom does improve with aging. Your pattern recognition, your ability to say, absolutely, that's what this is. There's some things that once you've seen them, you always know them. Most people get happier with aging, and you're more able to filter out unpleasant prospects. And that's why younger people get irritated talking to older people about the future, because I'm not going to die. Don't worry about the house. Our judgment can improve. Our experience can be great. Many people use gratitude. And, you can have more freedom as you get older because you aren't caught between your parents and your children in the same way any longer. So these are two other governors that were in my class. We're all aging. We all are survivors. But I think it's important to age well, to survive or escape or delay, adjust and cope. But probably the most important thing we need to do is be realistic about where we are and what our future looks like and how we can adapt and cope. So that's my presentation tonight. If you want some references, I can provide some, but I must say they were few and far between.
Dr. Newman, thank you so much. I would imagine if indeed participant could email us with questions or maybe start putting their questions in the chat box. I'm monitoring it. So that way, when we have time for the questions, we'll just, we'll go through that as well. Thank you so much. So it's our time to introduce our third panelist. Dr. Lauren Osborne is a director of the Center for Women's Reproductive Mental Health, and she's also associate professor of psychiatry and behavioral sciences and of gynecology and obstetrics at the Johns Hopkins University School of Medicine, where she's also directs a postdoctoral fellowship program in reproductive psychiatry. She's an expert on the diagnosis and treatment of mood and anxiety disorders during pregnancy, the postpartum, the perimenstrual period, and perimenopause. She conducts research on the biological mechanism of perinatal mental illness with a focus on neurosteroids and the immune system, and is the chair of a national task force working to create standards for education in reproductive psychiatry. Her work is supported by the Brain and Behavior Foundation, the Doris Duke Foundation, and American Board of Psychiatry and Neurology, and NIMH. Welcome, Dr. Osborne, and thank you for joining us today.
Thank you so much. I'm very glad to be here. Let me just share my slides. So I'm really pleased to talk to you today about perimenopause and what everybody in this room, I hope, needs to know about it. The other two talks were very specifically directed at women physicians, and mine is less directed that way simply because this is something that every woman needs to know about. Does it affect the work of women physicians? Absolutely. But it affects the work of all women. And I will, as we go through the presentation, I'll make some comments and call out specifically to how it affects work. So there was a great article in the New York Times, an opinion piece in the New York Times a few months back that was titled, "Women Can Have a Better Menopause. Here's How." And I happened to see this article on the day before a colleague of mine had to give a talk on menopause. And we talked about it and decided to incorporate it into all of our presentations because we really felt like it spoke to what the problem is with women's knowledge of menopause and knowledge of how it affects their lives. And so this article, and I encourage you to look it up, talked about the fact that, back in the early in the 20th century, girls didn't know what a period was. They weren't informed by their families what was going to happen to them. It was terrifying. And that now with menopause, we're kind of in the place where girls were with knowing about their periods 100 years ago. We don't talk about it. We don't know what's going to happen coming up. People aren't educated about it. And as a result, it can come as a big shock. And so the point of this article was to say, we can do better. Let's have a feminist menopause. We deserve to experience these changes in our bodies equipped with the facts and not with fear or shame or secrecy. And so we really need to go in equipped with education. And what I have found as I've talked to people about menopause is that it doesn't matter your scientific background. It doesn't matter that you're a physician and went through med school and allegedly learned some of this at some point. It's amazing how little knowledge a lot of women have about what the menopause transition is and how it's going to affect them. So I always like to start out by talking about a particular case and how menopause has affected a particular woman. So this woman, we're going to call her Lisa. She's 50 years old, she's married, and she has a history of depression, hypertension, and high cholesterol. And she noticed that she's not been getting her menstrual cycle for the last 4 months, and she's been more irritable, sensitive, and isolative. She had an earlier history of depression after her mother died, and she's been to counseling in the past, one other episode of depression after a pregnancy, and has had severe premenstrual symptoms, both physical and emotional symptoms before her period. So she's joined a support group, but she wants to know, what is this experience? Why am I feeling this irritability and sensitivity? And how common is this? And is there something that we can do to help my mood? So I think the first thing we have to talk about is, well, what is the menopausal transition? What does this word menopause mean? And a lot of people don't even know what that is. We think of menopause in the vernacular. Menopause is the period during which you're going through this transition, but that's not actually what it means. Menopause itself is a year to the date after your final menstrual period. That's what menopause is. So you can be considered postmenopausal 1 year after your final menstrual period. But the period in which women will have symptoms is actually the perimenopause, so the period leading up to menopause. And because the average age of menopause is 51, people tend to think, oh, this is something that's going to happen. People are going to have symptoms of this in the late 40s, early 50s. Well, that's true, but you can actually have symptoms for many years leading up to the menopausal transition. And the average duration of symptoms is actually 4 to 8 years, which is pretty long. I've had patients who've had symptoms for up to a dozen years. So when I see anybody who's in their mid 30s and beyond, I start to think about whether perimenopause could be playing a role in the symptoms they're presenting with. And that may sound crazy, 36-year-old, I'm asking about perimenopause, but no, if the average age is 51, she might get there at 48. She might have symptoms for a dozen years. I have to be thinking about it in her mid 30s. So this is just a graphic way of explaining what I just did. So there's the normal reproductive years, that's premenopause. Then there's this period of perimenopause, and then finally the last period, and then you're in menopause and postmenopause. So why does it happen? Again, we all learned this in med school, but it can't hurt to have a little refresher. And people tend to think, people think about pregnancy hormones as rising across pregnancy, and then you go over a cliff when you hit the postpartum. And that is how it works in pregnancy, but that's not how it works in menopause. In menopause, there's a much longer period of hormone fluctuation. So you see that there's this gradual decline in estrogen and progesterone that occurs over many years. And the period when women are symptomatic, either physically or emotionally, is this period that's shaded in blue. So this multi-year period as hormones are declining. And this is not a very accurate representation in this graph. Actually, it doesn't look like this smooth transition. It's a jagged transition. There's a lot of fluctuation in the hormones. And so there are a lot of myths around what menopause is and how it affects women in their both working and home lives. And I think one of the common myths I get is that it's easy for women to tell when they're in menopause. And so a lot of women will come saying, well, I'm still getting my period, so this can't be menopause. But the reality is, perimenopause lasts several years. Some women have no symptoms. Some women have many symptoms. So it's going to be a different experience for every woman. And the only way that you can pinpoint anything in the menopause transition is knowing when you enter menopause a year after your last menses. That's the only thing you can pin down for certain. Every woman is going to have a different length of time for the rest of the transition. Another myth that I frequently face is you can have your hormones tested and they'll tell you if you're in perimenopause. So I would say every woman who comes to me for a perimenopausal consultation wants me to test her hormones because she says, I must be having a hormone imbalance and that's why this is happening. But remember, I said before, it's not a smooth descent, it's a fluctuation and it's all over the place. So this is the normal cycling menstrual cycle in the premenopausal period. In perimenopause, it's all over the place. So could I test hormones and discover that estrogen is high or estrogen is low? And would that give me information? No, because it would depend on whether I tested hormones at this point or at this point. And on any day, you don't know where a woman is. So in theory, you can decide, well, what is the normal level of estrogen or progesterone or FSH or LH that a woman should be having at a particular point in the cycle. But if she's having irregular periods, we don't exactly know when her cycles are. So I spend a lot of time discouraging women from getting this done because it's not going to give us any more useful information than just me hearing what her symptoms are, learning that she has a change in her menstrual cycle, learning what the symptoms are. I know she's in perimenopause and I don't need the test to tell me. What kind of symptoms do women go through in the perimenopause? Both physical symptoms and emotional symptoms. And there are some fortunate women who don't have any of these symptoms at all. I don't think I've met anybody who didn't have any symptoms, but I've met many women who have very light symptoms and have met other women who are really debilitated by their symptoms. So again, it's very individual. Probably the ones that are most impairing are the vasomotor symptoms, more commonly known as hot flashes, low mood, impaired concentration and memory problems. And that's a really big one that I think many physicians who evaluate women in midlife aren't aware of. So we have the normal concentration and memory issues that happen as we age, as Dr. Newman told us about. But in addition, there are temporary concentration and memory problems that are associated with the menopause transition. And many physicians aren't aware of that or tend to dismiss it when women complain about that and don't take it seriously. But then there are also all of these other symptoms that are both physical and emotional symptoms. And in particular, sexual function, vaginal dryness, and changes in libido can have a huge impact on a woman's relationship with her partner and on that transition, making that transition to home life very challenging. So obviously I'm a psychiatrist. So one of the ones that affects me most is mood swings. And this can be different in different women. It can happen not only in women who have a prior history of a mood disorder, but also women who don't have any prior history. Women without a prior history are less likely to develop a full-on episode of depression, but they're very likely to have mood lability or mood swings. The women who are most at risk for an episode of depression in the perimenopause are women who've had a previous depression. And I just like to show this graph to remind everybody that mood disorders are much more common in women than in men, about a twofold difference during the reproductive years. And the reason I like to show this graph in particular is it really crystallizes how much the reproductive years are part of that. And there are both biological and psychosocial reasons for that. So you can see here we have female and male. And I should have pointed out at the beginning of the talk, when I say female or when I say woman, I mean people who have female reproductive hormones, people who can get pregnant, people who will go through female hormonal transitions. There are people who don't identify as female who do that, but the majority of the data that we have is based on women. So I'm using that word. And so you can see here that before puberty, girls and boys, same rates of depression, no difference. As soon as girls hit puberty, look at that skyrocketing rate up of depression for girls. And then it stays up throughout the reproductive years. And then there's a little spike here. This spike is the perimenopause. You can see this is the 40 to 49, 40 to 50 years. So there's a spike in depressive symptoms at the perimenopause. And then actually after menopause, you see that women's rate comes down to below that of men. And in the elderly, men are more likely to have depression. So I think this is an important graph to spend time on because it shows that reproductive hormonal physiology has probably got something to do with this, but there are also psychosocial things that go on during the reproductive years. As we've already pointed out on this panel, women bear the brunt of the work at home, and that is largely happening for women who do have children during those childbearing years. So what are the risk factors for actually developing an episode of depression in the perimenopause? So there are a number of different risk factors, demographic ones, the women who have younger age at the menopause onset. There are differences by race. Black women are more likely to develop depression at perimenopause, and women with lower education, low social support, stressful life events, just the same risk factors that we have for depression at other times, in fact. Women who've had prior history of depression or anxiety, and importantly, women who've had any other kind of reproductive psychiatric illness. So women who've had a postpartum depression or women who've had premenstrual symptoms are going to be at higher risk because those are the women who are vulnerable to mood symptoms around hormonal transitions. Things like smoking, elevated BMI, and then in addition, menopause-associated symptoms. So depression, hot flashes, and sleep disturbance are three independent types of symptoms in the perimenopause. A woman can have one and not the others, and they can exist independently, but they also affect each other. So if you're a woman who's really debilitated by hot flashes and you're not sleeping at night, of course, that's going to affect your risk for depression, but you can also develop depression independent of those factors. So remember our case that we talked about before, Lisa also notes that she's frustrated by the hot flashes she's having. She's using a vitamin that a friend recommended. This is very common. Women come in and they say, I don't want a pill, I want a vitamin. She wakes up drenched in sweat. She needs to change her clothes. And that sleep disruption has made her feel very tired at work. And she feels that's affecting her performance and her candidacy for a big promotion. And this is a really important factor to think about for women physicians going through perimenopause. That sleep disruption, whether it's associated with hot flashes and depression or not, can be really debilitating. Women can have incredibly broken sleep, get only a couple of hours of sleep at night. And it's one thing to do that when you're 25 and a resident. It's quite another thing to do that when you're in your 50s and you probably have different kinds of responsibilities at work, and it can really affect your functioning, obviously, as a physician. The hot flashes and night sweats are more common than any other type of symptom in perimenopause. About 85% of perimenopausal women will experience some kind of vasomotor symptoms. They can either be spontaneous or they can be triggered, and how it's triggered is different in different women. As I said, they can interrupt sleep and be associated with depression, but they also exist independently. And the average length over which hot flashes last is about 5 years. So that's a long time. And even the hot flashes can even last past menopause. So we think of menopause as that 1 year after your menses. Well, the hormones should be low by then, that vasomotor symptoms should have retreated. But the reality is there's still some hormone being released and there's still some fluctuation going on. So the vasomotor symptoms can last long past that transition. So how do we treat these kinds of symptoms and how do we think about treatment in menopause? I think there's a lot of misinformation out there about it. The first line treatment actually is antidepressants, whether it's for depression or for vasomotor symptoms. There are a couple of antidepressants that are FDA approved for hot flashes. Hormone replacement therapy, but it's really important to remember that that should be used in perimenopausal women, but not postmenopausal women. If you add the two things together, hormone replacement therapy and antidepressants, there's an additive benefit. So many women may need both kinds of treatment. Hormone replacement therapy is another thing around which there are a lot of myths. And I'm using the term hormone replacement therapy because that's the term most people know. It's now more often called menopausal hormone therapy. And the myth is, of course, that it's not safe, but the reality is it's just not that simple. So hormone replacement therapy consists of estrogen-derived products, which are delivered with progesterone for women who have intact uteruses. And by 1975, was shortly after it was introduced, estrogen was actually the 5th most prescribed drug in the US. But then we had the Women's Health Initiative study, which was stopped in 2002 after it showed an increased risk of coronary artery disease, strokes, and invasive breast cancer. And they developed this tremendous fear of hormone replacement therapy. Prescriptions fell, and women felt that they had to suffer through this transition without any treatment. But the reality is that the cohort in that Women's Health Initiative study was not representative of the population for whom we could and should be prescribing hormone replacement therapy. So it was older women, it was women long past the menopause transition who had those increased risks. And if we use hormone replacement therapy around the time of the menopause transition and not for super long time, those risks are eliminated. So with women who are younger than 60 and are within 10 years of menopause and don't have any other contraindications, the benefit to risk ratio is most favorable for treatment. So it's something that I have to explain a lot to patients who have heard that hormone replacement therapy is dangerous. And physicians are equally have heard that, and probably sometimes even more than people who aren't physicians. So this is just an algorithm of the way I think about how to consider and treat symptoms through the perimenopause. So if the patient is presenting me with vasomotor symptoms that affect her life, I think about, is it just vasomotor symptoms or is it vasomotor plus mood? And that's going to affect how she's treated. So if she has evidence of a mood disorder, then the simplest thing to do is start with an antidepressant because that's indicated for both. If she has no mood symptoms and has medical contraindications to hormone therapy, you could try a low dose antidepressant that's just for the hot flashes, or some symptomatic treatment like gabapentin or clonidine, which both can be effective for hot flashes. If she has no mood symptoms and she has no contraindications to hormone therapy, then by all means, we should be prescribing that. But if she has no mood symptoms and no contraindication to hormone therapy, but she really doesn't want to take medication, we can try some alternative treatments about which there are growing amounts of evidence. So here's the current recommendations on the different types of treatments we can use in the menopause transition. The green ones are the ones that I just talked about on the previous slide. There's a little bit of evidence to show that weight loss can be effective, and as can mindfulness-based therapies, either mindfulness-based stress reduction or mindfulness-based cognitive therapy. But then there's a whole lot of things that we just don't have evidence to recommend that many people will want to try. Various herbal supplements, yoga, exercise, these are all good things to do, and women should absolutely do them to feel better, but we don't actually have evidence that those are going to affect the symptoms of the menopause transition. The other thing I want to just, spend a little bit of time on is the idea of cognitive effects. And this is something I'm actually working with a med student now who's writing a commentary piece on our understanding of cognitive effects in menopause. And the reason I think it's so important is that I think out there in the culture, we think of menopause and we think about hot flashes. That's the most common symptom that people think about. And then I think a lot of people understand that there may be mood changes or irritability that happens during menopause. Very few people are aware of the cognitive effects. And what that means is that women are surprised by these effects when they happen. And when they complain to their doctors about these effects, the doctors tend to dismiss them because they don't think it's real, or they chalk it up to just common aging effects, and they don't take it seriously. When the reality is that that it's common, well documented, that there's a brain fog. People can have trouble remembering names, more trouble with organization and planning, poor concentration, basic executive function problems. The good news is that it's time limited, and that for the most part, these symptoms are not associated with cognitive decline. So it's a temporary thing through the menopause transition as we're having these hormonal fluctuations. And there's treatment. There's some really good evidence that stimulants can help, particularly good evidence for lisdexamfetamine. And I think that we just have to listen to women and understand what they're going through. This, I think, is a particularly important point for women physicians, because, of course, menopause is happening at a time when women are reaching midlife, and they may fear that these kinds of symptoms that they're having are signs of aging and decline, and they may fear that their skills are going into abeyance and that they need to think about stepping back from work. And that may be the case, right? They may be having a cognitive decline associated with aging, but they may not. And it doesn't make sense to dismiss that without trying to evaluate and treat the symptoms, and maybe keep women productive and working if they want to be for longer than would otherwise be the case. So what do we think about how we should be thinking about menopause in the future? And this, again, is back to that New York Times article I mentioned at the beginning. And I just love that menopause isn't a death sentence, right? We have to dispel the notion that a woman's worth is tied to her age and her level of estrogen. We need to just think of this as a new phase of life, and one landmark along the way, and one that can be incorporated into our lives as working physicians. And when women need help navigating those symptoms and the health implications, they need to be given clear, non-sexist information, and there should be proven therapies available. And I think one of the people who work in my field, reproductive psychiatry, understand how reproductive transitions affect mental health or cognition, but most psychiatrists don't. Most psychiatrists don't have that knowledge. And so if they're presented with a woman in midlife, they won't even think about the fact that menopause could be considered. And I feel like it's one of my missions in life is to make sure that psychiatrists who aren't reproductive psychiatrists understand that that's important, and that they always need to think about not only the age of a patient who sees them, but the reproductive status. I'm sorry, I put my Zoom faces over where I need to move my people. Here we go. Okay, and so that's the end of the formal talk. I'm really happy to have conversation and questions about it. But before that, I want to just give a shout out to all the people who helped me in my work.
Thank you so much, Dr. Osborne, for such detailed and hopeful presentation. I appreciate that. I think this would be time for us for next 10-15 minutes to see whether those who participated in audience have comments, questions. You're welcome to either raise your hand or use a raise hand option, or unmute yourself, or put the chat box, whichever is more convenient. I see Dr. Shirina Tai, PGY1 from this wonderful residency, and Randall is wanted to say something. Please go ahead.
Yeah, hi. This was a really interesting topic, and just fascinating information. I'm overwhelmed. I always knew that there was some inequality, like, socially, economically, and of course biologically, but all this data, yes. So now my question is, I don't know, maybe it could go to Dr. Kuhl, who talked about the daycare, and just with all this knowledge that we know that there are a lot of things, need to be changed in order to female doctors, women doctors, to be, to achieve the same goals, or, aim the same career goals as men do. But what do you recommend the young female doctors, do what kind of forgive my ignorance. I know that there is AWMA, but I really don't. Of course, there's a feminist struggle going on in the country and in the world, but what do women physicians do in general for their rights? What kind of organizations are there, and what can we do to, improve our work environment? And yeah, that's my question. I don't know if you, thank you.
Thank you. I think what I hear is it's overwhelming as a woman physician and trying to figure out where do I get more engaged and involved so that I can learn better. Is that kind of what you're trying to ask, Siren? How to get better involved?
I'm asking what kind of, I know that just me, I cannot change the whole system, but I have to organize with the other female physicians. So I'm asking what kind of cases, what kind of organizations are there, and what's the this is the data, but what are we doing to change this, change our destiny?
So I think there's the American Medical Women's Association that I mentioned, and some of the work they're doing around educating women about fertility. I'm not too familiar with them as much, but certainly I can speak to our Women in Medicine group in the American College of Physicians as a place to get involved and educate each other and talk about things. In terms of making changes in policies and rules, that's a longer term process, and certainly many of these organizations have a political arm that works to change rules, including ACP, that has a very active role in how laws are made and things changing. Certainly, there's a much bigger emphasis in graduate medical education to increase the time off for women who may be having children during residency, and to minimize its impact on their future career.
Well, and there has been lots of change. I mean, they didn't even have anyone to say what I could possibly do. They had to form a committee of a bunch of men to let me have maternity leave. So there's been a lot of change, and I think it's consistently changing over time. And I think many of us support each other over the years. So, but I think it's important to keep saying exactly what we need, not just what has historically been done. So.
Thank you so much. And I agree with Dr. Pooh that Shireen, you already took the first step in attending this and being part of this as a part of ACP and being aware of this. So thank you. I see Dr. Barry Meisenberg raised his hand. Thank you so much for joining us today.
Well, thank you for the very interesting set of talks. I apologize that my video is not available. I'm on low signal strength, and I assure you it's really to your advantage that it worked out this way. So I would ask, and each of you has mentioned a New York Times article, so we all must read the same newspaper. And I was a little surprised that you didn't cover the issue of meager paternity leave and maternity leave. And although that's a national scandal, there was an article in the New York Times comparing the United States with other countries, advanced and less advanced economically. And specifically with regard to women in medicine, which is the topic tonight, House officers, residents, and many physicians work for health systems that ought to know better. And it obviously affects not just physicians, but it affects many kind of workers who, because we have, in general, a highly female workforce in hospitals. So I'm wondering if any of you have tried to pursue that angle at the institutions you work for. And then my also comment on the issue of sleep deprivation, even after a baby, and how that affects trainees.
I mean, I'll just jump in to say that a colleague of mine is working on a paper where she gathered data from an app that women use to track their menstrual cycle, and they can also track their pregnancies through it. And so she has worldwide data from something like 25 different countries on postpartum depressive symptoms, and she's looking at it compared to economic factors. And one of the very clear things that's coming out of the data is how directly the postpartum depressive symptoms are related to the length of paid leave in the country. So the shorter the paid leave, the more likely there are to be postpartum depressive symptoms. And I think it's it's not surprising.
I think now is the moment to make progress, because, hospitals across the country are scrambling to retain employees. I work at Loomis Health, and I can tell you that they have reevaluated a lot of things that they used to put off the table as too expensive, but it's not as expensive as hiring agency staff.
Exactly.
And then I just want to make one other comment, is that there is an extensive literature on musculoskeletal injury in surgeons, particularly doing laparoscopic or robotic procedures. And this is a well-documented phenomenon of degenerative arthritis in the neck and back. But depending on the kind of surgery, also elbow and shoulder. And it's got to do with the unusual body positions that surgeons have to put themselves in while using those scopes. So I'm many decades away from being in the operating room as a student, but I do know it's a live issue, and I'm not sure they know what to do about it, but they're very, very concerned about it. So if we get arthritis from typing, if internists do, I wasn't aware women get it more often than men, but they've got their own set of significant issues there.
Well, actually, I think what happens is that we get it 10 years younger is the problem. That we're just we're more prone to CMC osteoarthritis.
Yeah.
And the onset is younger in women.
Yeah. So, but I'm saying is that for the surgeons, they've got the same sort of workforce concerns with surgeons exiting the OR at 10 or 15 years before they would otherwise, because of this exact issue.
And if all of a sudden half of the surgeons are women, and we have an earlier onset, the career longevity changes. So there's a lot that needs to be done on physician workforce.
Yeah. Well, it won't be all of a sudden. You can predict that it's what it will be, but yes, it will. You're making a good point.
So there were great points about the time off and paternity leave and maternity leave. I think those are very legitimate points. It was just beyond the scope of all the things we wanted to talk about today. It was quite overwhelming, but thank you for bringing up those great points.
And thank you for being with us, because I think my refrain is, to support the women in medicine, you don't have to be a woman. In fact, the more we get support from all around, the better. Thank you. I see Dr. Waite next, and it would be probably our last question for tonight.
Yes. Hi, I'm Dr. Waite. I'm a radiology resident at Walter Reed. And this topic of infertility really hit home for me with PCOS and making the diagnosis on myself in medical school. I had several female mentors who encouraged me to just go for it, trying to get pregnant in medical school. And I had my first baby the day before intern year started. But several programs I interviewed at, one of which said that there was a 1-week maternity leave, was not the place I ended up. And I'm really blessed to be in the military, where they allow us to take 3 months maternity leave. But I guess my question is, I don't have the luxury of time knowing that I already have infertility problems at a young age. now trying to bridge the gap of trying to decide when to have a second kid and wanting to still be taken seriously and like almost prove myself that I'm serious about medicine, but also taking, having another baby is also a priority, is something that I'm struggling with for having a second kid in residency stretched out over 5 years.
Well, I really thank you for sharing your story and congratulations on your first. I think that's wonderful news. Boy, these are not easy decisions. That is one thing I would say. There are so many factors you have to think about and juggle what your resources, support systems are. It's such a personal choice, but at the same time, if you know you have challenges, I can see how that would make you feel pressured to have a kid, even when you're not maybe feeling ready for it. I don't know if Mary or Lauren would like to comment on this.
Yeah, I think there's never any good time or right time. And because we don't have maternity leave and we don't have all the things that we need to support women through this decision, I'll tell you that I did it backwards. I had my kids and then I went to med school. So I got all the childbearing out of the way first, but that's not the way most people do it. And I think that there's a constant war of trying to show that you're dedicated to medicine and also trying to be a dedicated mom. And I think, until we really do succeed in getting some of the protections for working moms that most other developed countries have, and many developing countries have, that it's just going to be always a challenging personal decision. For me personally, I would say having your kids is probably the most important thing in your life, and don't put anything ahead of that.
Yeah, I know over the years, I've always said, your children inconvenience no one more than you. So go for it when you can and want to. And it's easier to get pregnant and it's easier to have children when you're younger than when you're older.
Mm-hmm.
So,
yep.
And I know I had my children before. I have 3, and I had a son, and then 5 years later, a daughter, and then another daughter. But I must say that having the children when you're building your career, you can always make space for them. There's always, they already fit.
Mm-hmm.
Yeah, if it's important to you, you have to go for it, and the work will come. The work will always be there.
It will.
and now there is new changes in the rules so that there is maternity leave and protected time. ACGME just had a new resolution. I can send you the details later if you're interested, but it does allow you to have more time, at least 6 weeks and 8 weeks for C-sections, without having to compromise the length of your training.
Is it retroactive?
That's a good one. I would like to have it be retroactive too. Hang in there, you're not alone. But thank you for sharing and go for what's right for you. The rest, your career will sort itself out. If you're dedicated, no one can take that away from you. You just do what you need and what's right for your family.
Thank you.
Thank you, everybody.
Thank you so much to all who were here today and those who supported us, whether they were here today or not. We're looking forward to our next meetings, and the recording of this meeting will be available on the YouTube channel very soon. We will be sending out survey. We'd like to hear your reflections on this get together, and what type of topics you would like to address next time, the specifics for, like, especially for women in medicine. And we really appreciate your being here, and thank you for sharing and being open and being kind to all of us. Enjoy your evening. Have a good one. Thank you so much.